Good morning. This is Dr. Eshvanthni, Senior Resident, Department of Anesthesiology. In this video, we'll see about the declaration of brain death and management in an organ donor. The objectives are, we'll see a brief about the history, the TOTA Act, mechanism of brain death, declaration, checklist and certification, pathophysiology and organ donor management. Starting with the history. In 1959, the term coma de passe, an irreversible coma, was coined by Mollaret and Gowland. In 1968, the ad hoc committee of Harvard Medical School defined brain death as a total loss of movement and respiration, of brainstem reflexes and unconsciousness. The criteria of irreversible coma is termed by four. One is an unreceptivity and unresponsivity, no movements of breathing, no reflex, and a flat EEG. Repeat at least 24 hours with no change and exclusion of hypothermia, that is temperature below 90 °F or central nervous system depressants. Mohandas and Shaw published that injuries of the brainstem are important aspects of severe brain damages. In 1976, brain death was defined by the Conference of Medical Royal Colleges as a complete and irreversible loss of function of the brainstem. In 1981, the UDDA Act, that is Uniform Determination of Death Act, was passed, according to which an individual who has sustained either irreversible cessation of circulation and respiratory functions or irreversible cessation of all functions of the entire brain, that is including the brainstem. American Academy of Neurology guidelines on brain death, according to 1995 Act, irreversible loss of entire brain, including the brainstem, has been determined by the demonstration of complete loss of consciousness, brainstem reflexes, and independent capacity for ventilator trial. Neuroendocrine function may persist in patients with irreversible injury to the brain and brainstem. Ancillary testing serves only as a surrogate means of assessment. Irreversibility refers to the impossibility of recovery regardless of any medical intervention. Differentiate brain death from other forms of severe brain damage, including vegetative state and minimally response states. Transplantation of Human Organs and Tissue Act, that is the TOTA Act, in 1994 was passed. The purpose of this act is to regulate the removal, storage, and transplantation of human organs for therapeutic purposes and for the prevention of commercial dealings in human organs. This act was amended in 2011 and the amended act is named as TOTA. Under this act, brainstem death is recognized as legal death in India. The brainstem death, that is stage at which all functions of the brainstem have permanently and irreversibly ceased and is so certified under subsection 6 of section 3. A deceased person is a person in whom permanent disappearance of all evidence of life has occurred by reason of brainstem death or in cardiopulmonary sense at any time after birth has taken place. A declaration of brain death, which includes four doctors in the panels, and the brain death certification is done. The four members, or one is a hospital administrator and a resident doctor of the hospital, a neurologist, neurosurgeon or physician, intensivist or anesthetist, and the treating doctor of the patient. The mechanism of brain death. The sources can be either traumatic, either cerebrovascular injury, and even generalized hypoxia, all produce brain edema. It can be either vasogenic or cytotoxic. In vasogenic edema, there is increase in the cerebrovascular permeability after leaking of serum proteins into the brain parenchyma. Whereas in cytotoxic brain edema, in hypoxic and ischemic condition and results from disturbance of the osmoregulation vessels. In this type, the blood-brain barrier will be intact. Brain edema may be focal at first, then spreads throughout the whole brain. This increases the intracranial pressure. The critical cerebral perfusion pressure is a normal range of 10 to 20 mm of Hg. Increased intracranial pressure compresses the entire brain, including the brainstem, and the uncal and the tonsillar herniation and total brain infarction occurs. The medulla oblongata has the longest survival time. Checklist for brain death determination in case of adults. There are 5 steps. The first step includes a prerequisite to examine. So we have to rule out all these conditions before evaluation. All of the following conditions should be corrected before beginning the brain death evaluation. One is hypotension. If hypotension is present, it has to be corrected. it refers to a map of less than 65 mm of Hg. If hypothermia present, it has to be ruled out and corrected, which indicates a core body temperature less than 32 degrees Celsius. Hypothyroidism, similarly hypoglycemia, and even effects of CNS drug depressant should be ruled out and corrected. And the step 2 is establish the cause of coma. The cause of coma is known and is sufficient to account for the irreversible brain death. Step 3 is absence of brain and brainstem functions. This step involves two sequential exams. One is step A, that is the patient is comatose, that is unaware and unresponsive. And the step 2 is once the patient is unaware and unresponsive, all the brainstem reflexes should be elicited and checked whether they are absent. So it corresponds like it comes under like absent pupillary response to bright light, absent corneal reflex, absent gag and cough reflexes, absent oculocephalic reflex, and deviation of eye with cold water stimulation of the tympanic nerve, right? Which we will see in detail at further. And step 4, it's absence of spontaneous breathing efforts. That is, there is no spontaneous breathing effort when the arterial PCO2 is 20 mm of Hg above the patient's baseline. This refers to positive apnea test. And step 5 is consider confirmatory test. That is involving all the 1 to 4 steps which cannot be completed or unequally interrupted. And the confirmatory test includes EEG, transcranial Doppler flow study, somatosensory evoked potentials, brain scan with technetium 99, and cerebral angiography. These are the confirmatory steps. And the findings for specific steps is like in nuclear scintigraphy, the finding is an absence to uptake. And in cerebral angiography, no filling of intracranial arteries will be there. And EEG, there will be isoelectric activity and lack of reactivity to a stimuli. And in transcranial Doppler, there will be absence of diastolic or revertebrating flow. And motor response to pain will also be absent. No motor response to pain in distribution of any cranial nerve. No motor response to painful stimuli of the trunk. Central pain assessment can be done by applying a noxious stimuli over the supraorbital notch or angle of mandible sternum and upper trapezius or anterior axillary fold. The spinal reflexes can be present in patient with brain death. Loss of brainstem reflexes. Like for assessing, first you check for pupillary light reflex. It is carried by the afferent and efferent or second and the third cranial nerve. Here the pupils will be fixed or mid-size dilated, that is around 4 to 9 mm. It's not responsible, they are not responsive to light. Loss of corneal reflex. This indicates the afferent and efferent of 5th and 7th cranial nerve. The vestibulo-ocular reflex is elicited. This is also termed as caloric reflex, and the afferent is carried by the 8th nerve and the efferent by the 3rd and the 6th cranial nerve. After installation of 50 ml of cold water into each external acoustic meatus for 1 minute, no eye movement will be there. Whereas in case of reflex present, the eye will be moving in opposite direction. Oculocardiac reflex, oculocephalic reflex, oculocephalic reflex, doll head eye movement reflex. Here the apparent is 8th nerve and the efferent are 3rd and the 6th cranial nerve. Absence of the conjugate deviation of eyes when head is fully rotated to one side. In normal condition, when head is rotated to one side, the cornea will move to the opposite side. Whereas in case of brain, this eye movement will be absent. It is performed only when the fracture or any cervical spine instability is ruled out. This test can be performed. Loss of gag reflex, it is carried via the 9th cranial nerve. It is in order to, here the posterior pharyngeal wall will be stimulated and checked for. Loss of cough reflex, which is carried by the 10th cranial nerve. It can be assessed using a suction catheter in a trachea. Apnea test. The aim is to check for the integrity of the brainstem respiratory center at high levels of blood carbon dioxide. Absence of respiratory efforts in presence of hypercardia and acidosis is consistent with brain death. The prerequisites for this is to rule out other conditions like core body temperature should be minimum of at least 36 degrees Celsius. Hypothermia should be ruled out. Euvolemia must be there and the hypotension must be ruled out so that the systolic blood pressure must be around 100 mm of Hg. Eucapnia and absence of hypoxia so that the partial pressure of carbon dioxide should be around 35 to 45 mm of Hg. Blood pH should be normal to basic, low basic levels. Should not be performed if patient is under effect of any paralyzing drug so that the patient can't take efforts. So the procedure is First, we have to pre-oxygenate the patient with 100% O2 for 10 minutes so that the partial pressure of oxygen is more than 200 mm of Hg. Now, we have to disconnect the patient from the ventilator. We have to place a catheter through the endotracheal tube close to the level of carina, and 100% O2 at 6 liters per minute flow is being delivered. Look closely for any respiratory efforts in the patient for 8 to 10 minutes. Respiration defined as chest or any abnormal excursions in the patient. Patient with intact brainstem is expected to breathe when there is CO2 accumulation, which develops at a rate of 3 mm of Hg for each minute. And this test to be aborted when the systolic blood pressure falls less than 90 mm of Hg or the saturation falls below 85%. For more than 30 seconds, if this lasts, we have to abort the test and connect the patient to ventilator. If no respiratory drive, repeat an ABG after 8 minutes. If respiratory movements are absent and arterial PCO2 is 60 mm of Hg or more, that is 20 mm Hg more than the baseline. So it indicates that apnea test is positive. If test inconclusive, but patient hemodynamically stable, test may be repeated for longer periods like after 10 to 15 minutes. The complications of this test is patient may go in for hypoxemia, acidosis, hypotension, which may ultimately lead to cardiac arrhythmia and MI. So this is a brief of checklist for determination of brain death. As we have seen, all the tests as first initial prerequisites to be done and the examinations to be done and rule out and apnea test. Once it is confirmed, the confirmatory ancillary testing can be done. That is the cerebral angiogram, HMPAO spec, EEG, ECG. There is something called as Lazarus sign. A brain death patient can exhibit brief spontaneous movement of the head, torso, or upper extremity, especially after they are removed from the ventilator. These movements are a result of neuronal discharges in the cervical spine cord, possibly in response to hypoxemia. This doesn't mean that the patient is not brain dead. Certification of brain dead. As discussed earlier, there are 4 members required for the committee to certify a person as brain dead. Okay, in India, it has a rule that 2 tests has to be performed, a minimum of 4 hours apart. The time of death has to be certified. Time when PaCO2 reaches its target value during second apnea test has to be noted. After confirming by doing the post-ancillary testing, when first test confirms the absence of brainstem reflexes. This is a brainstem brain death patient certificate used in India. It's called as Form 19, and you can have a look at it. It shows the 4 members involved in the committee, that is the registered medical practitioner in charge of the hospital and the person nominated by the panel, and either a neurologist or neurosurgeon, even anesthetist, whomever is included, and the treating doctor of the deceased person. And this is how the certificate looks. If the patient is a pediatric child, a pediatric brain death, you'll just see certain important clenching points. Establish a brainstem injury, whether it's irreversible, and the cause of coma has to be established. Consider differing brain death evaluation for 24 to 48 hours after resuscitation. And when in doubt, observe or postpone brain death evaluation. Exclude mimicking conditions and correction of metabolic derangement as discussed earlier for same as that of adults. And neuromuscular blockade, if any, should be addressed and corrected. And any drug intoxication should be addressed and corrected promptly. And make sure that the temperature is above 35 degrees Celsius. Neurological examination, how it varies from adults to children. Like number of examination is same, 2. And observation period. If the age of the baby is more than 30 days, 12 hours observation is enough. If age is 37 weeks, estimated gestation, according to estimated gestation age of 30 days, then 24 hours observation must be done. 2 different attending evaluators must be there. And for pediatric, the primitive reflexes for neonates and infants accordingly has to be checked, and discusses the spinal reflexes. And this is a comparison between and adult and pediatric for different state guidelines like United States and Japan. If you want, you can have a look at it. And the summary. Ultimately, for a brain dead declaration, we must identify the cause of coma. Any confounding factors like hypotension, hypoglycemia, any metabolic derangements, drug intoxicity, this must be ruled out. And we have to perform the brainstem reflex test and apnea test and ultimately confirmatory test. And manage institutional protocol while informing the family members and manage patient if a patient is a potential organ donor. This is the organ donation process. For organ donation process, it involves the cooperation of the doctor, family members. Like we say, a primary and secondary brain injury will be there. The person will be diagnosed as a brain death and reporting for the potential donor, whomever is, and we have to discuss it with the family. Medical examination must be done on the deceased patient, whether they are eligible for organ donation or not. Data transfer for the transplant association for organ allocation and organ harvesting, organ transport, and then finally transplantation occurs. Pathophysiology of brain death. As seen already, like traumatic brain injury and subarachnoid hemorrhage are the most common causes of intracranial events leading to brain death. It has an initial autonomic storm followed by a late phase. So lots of neuroendocrine changes will be happening. So during the autonomic sympathetic storm, these are the things happening like critical ischemia and subsequent infarction of the brainstem, which is associated with intense autonomic activity and massive catecholamine release will be there. This results in an increase in heart rate, BP, cardiac output, and the systemic vascular resistance. And central redistribution of the blood volume will be there. So this adversely affects the myocardial O2 demand supply ratio, or it may lead to thereby leading to visceral ischemia. From the ischemia progression will be rostral to caudal, that is cerebrum first, involving the it causes vagal activation. So after that storm, there will be decrease in heart rate, cardiac output, and BP. From in pons, there will be mixed vagal and sympathetic stimulation, thereby decrease in heart rate, increase in BP, and irregular breathing pattern will be there. In medulla oblongata, sympathetic stimulation only happens. This results in autonomic storm, increase in heart rate and BP. Hypothalamus destruction, thereby hypothalamus as a temperature regulatory center, there will be thermoregulatory impairment will be there. And pituitary, if it's destructed, there will be endocrine dysfunction. And spinal cord, sympathetic deactivation will be there, thereby decrease in heart rate, cardiac output, and BP will be there. So loss of brainstem functions. There is loss of vasomotor control, loss of respiratory function, loss of temperature regulation, hormonal imbalance, and cardiac arrhythmia will start. And neuroendocrine changes. Diabetes insipidus is the most common and the earliest hormonal abnormality of a brain death and is defined as urine output in excess of nearly 250 ml per hour for greater than 2 hours, and a urine specific gravity will fall. It will be less than 1.005. So this is the first most important neuroendocrine change occurring in majority of the patients, like around 46 to 87% of the patients. This is usually followed by decreased thyroid stimulating hormone secretion, resulting in rapid decline in the level of free triiodothyronine. Thyroid failure causes depletion of high energy phosphates and impairs the cardiac contractility, favors anaerobic metabolism, and thereby increase in lactate levels. Brain death also leads to hormonal derangements that frequently precipitate hyperglycemia. So, which is further exaggerated by the release of epinephrine, exogenous steroid administration, or infusion of dextrose containing solutions. So, donor stress responses are blunted due to adrenal insufficiency and decreased level of cortisol and adrenocorticotropic hormone. This contributes to hypotension, cardiac instability in these patients. Pulmonary changes. In pulmonary, the catecholamine storm will in turn increase the systemic vascular resistance, which in turn increases the pulmonary overload, and which in turn causes neurogenic pulmonary edema. The release of catecholamines during the initial hypertensive and hyperdynamic period after brain death also causes elevated cytokine levels. It leads to pulmonary endothelial damage and capillary distribution. Other causes of lung injury in this setting may be trauma, aspiration, pneumonitis, fat emboli, and ventilator-induced lung injury. Regarding glucose imbalance, it rarely hypoglycemia may occur, but the most common thing is hyperglycemia. It may be, as discussed earlier, it may be because of excess of resuscitation with glucose-containing fluid, and the other is insulin deficiency and stress response to injury and exogenous catecholamine. So hyperglycemia is very common. And thermoregulation, as the hypothalamic pituitary axis ischemia is there, loss of temperature regulation happens, and this may lead to myocardial depression, coagulopathy, refractory dysarrhythmias, and kidney impairments. Hematologically, coagulopathy can occur in an isolated head injury and associated with a worse outcome. The release of tissue factors along with cerebral gangliosides and plasminogen-rich substrates from the injured cortical parenchyma contributes to the development of coagulopathy. Sometimes it may further progress to even DIC. These are the incidents of pathophysiologies after brain death. The most common is hypertension, followed by diabetes insipidus, and then disseminated intravascular coagulation, cardiac arrhythmias, pulmonary edema, and least is acidosis. The goals of organ donor management. To achieve a hemodynamic stability, maintain adequate organ perfusion and oxygenation, improve function of transplantable organs, increase number of organs per donor, successful organ recovery. These are the goals of organ donor management. Donor assessment and evaluation. First thing is early identification and doing investigations for the disease and the receiver, and monitoring of the patient, successful resuscitation, and dealing with the complications of brain death until the organ is harvested. This begins after the brain death with donor designation or family authorization. Detailed medical history regarding the donor is collected. A complete physical examination is performed. Cause and time of declaration of brain death has to be noted. Review of any current hospital courses should be done. Organ specific functions should be recorded. The age, infectious disease stated, and screen for malignancy or a transplant team to be activated, and information should be passed. Regarding monitoring, ECG, pulse oximetry, ABG, CVP line, Foley's catheter, temperature monitoring, blood sugar and electrolyte, LITCO, serial echo, pulmonary artery catheter monitoring. These all to be done. These are the investigations to be carried out for an organ donor. Like with routine investigation, serum electrolyte, including the total CO2, glucose, the renal parameters, other electrolytes to be checked for, along with calcium, magnesium, phosphate levels, LFT to be done, and all the serum levels to be assessed, protein, albumin, and cholesterol parameters, lipid profile to be done, C-reactive protein, erythrocyte sedimentation rate, procalcitonin, creatine phosphokinase, and the urine analysis, hemoglobin, HbA1c, other hormone profiles to be done, and serology, everything to be done. These are the relevant tests to be done. You can have a look at it. HLA cross-matching to be done, and other virology, serology parameters, culture sensitivity, blood and urine sputum, and 24-hour sampling to be done. Regarding imaging, chest X-ray, PA view, hepatobiliary and kidney ultrasonogram, abdomen, pelvis and CT scan, brain CT. These are to be done, and patient should be optimized and resuscitated accordingly before harvesting. Practical aspects of organ donor management. That is, the initial phase will be, because of the storm, there will be severe hypertension. This is managed with short-acting beta blockers. And the next phase is a severe hypotension. This is a phase that possesses great risk of organ viability. So it must be managed with volume resuscitation and vasopressor agents. So the hemodynamic goal and a brief of how to manage the patient. Our hemodynamic goal is to maintain a mean arterial pressure more than 60 mm of He and an urine output of more than 1 ml per kg per hour, and the left ventricle ejection fraction must be more than 45%. If this is not met, we can start with ionotropes. The first choice is with dopamin or dobutamine. This is not more than 10 micrograms per kg per hour. The further is the goal is not achieved, the pulmonary artery catheter can be inserted, and the cardiac index, pulmonary capillary wedge pressure, and systemic vascular resistance, these all can be monitored for. Even nowadays, pulmonary catheter, instead of pulmonary catheter, more of tracheoesophageal echocardiography can be used as a substitute for better monitoring of the hemodynamic and cardiac status and management of the patient. If the cardiac index is less than 2.5 liters per minute per meter square, then assess for the CVP or pulmonary capillary wedge pressure. If it's further low, you can resuscitate with fluids. if the systemic vascular resistance is less than the normal value. Now, vasopressors like norepinephrine or epinephrine can be given. If the pulmonary capillary wedge pressure is more than 12 mm of Hg, then dopamine, dopamine, and epinephrine, these things can be given. Ultimately, fluid and inotropes to be given and resuscitated. So these are the different things that stress the organ system. The heart, fluid excess can stress the heart. So fluid management must be done. For lungs, fluid excess can cause alveolar infiltration and it renders the lung untransplantable. Whereas for kidney, hypoperfusion can stimulate acute tubular necrosis or injuring the kidney and complicate recovery. For liver, a less volume sensitive expect in severe volume depletion and shock. In case of pancreas, it needs perfusion but is less volume sensitive. For bowel, hypoperfusion can cause organ damage. So based on the organ to be harvested, the fluid management must be carried out. Pulmonary support. So this is regarding the lung support and ventilator management. Patient must be in head-up position. And lung protective ventilation strategy must be followed. That is a tidal volume of 6 to 8 ml per kg with a PEEP less than 5 and Pmax less than 30 centimeters of water to be given. And with lowest possible FiO2 kept, the SpO2 to be maintained such that it is more than 95%. Maintenance of normocapnia, that is the PaO2 is around 30 to 35 mm of Hg. Pressure control ventilation mode is much preferred and recruitment to be done intermittently in order to prevent alveolar collapse. Strict asepsis to be followed. Physiotherapy with hardly gentle inflation of lung and 2 hours side to side turning. And up-to-date chest X-ray must be taken. Broad spectrum antibiotics to be started. Every 2 hourly ABG to be taken or whenever it is indicated. Extravascular lung water can be minimized by the early use of steroids like methylprednisolone or by avoiding a positive fluid balance. Endocrine support. The most common condition is diabetes insipidus. So, the patient it is defined as urine output more than 4 ml per kg per hour, and serum sodium level will be in a rising trend. It's more than 145 millimoles per liter, and the serum osmolality is also more than 300 milliosmoles per liter. Whereas the urine osmolality is decreased to less than 200. So for this, the management goals will be in order to titrate the urine output less than 2 ml per kg per hour and volume replacement for the more the fluid loss and maintain the serum sodium levels with less than 155 millimoles per liter, not more than that. And vasopressin can be injected like 1 unit bolus and 0.5 unit per hour as an infusion can be given. Vasopressin is used in donors with hypotension despite adequate fluid resuscitation or with excessive urinary output as in diabetes insipidus. Desmopressin is used for hyponatremia in diabetes insipidus without hypotension. A typical dosing regimen for vasopressin is an initial bolus infusion of 1 unit followed by a continuous infusion of 0.01 to 0.1 unit per minute. Typical doses are 0.01 to 0.04 units per minute, thereby titrating to a map of 65 mm of Hg. Thyroid dysfunction, a sick thyroid syndrome may manifest. So, use of T3 improves the tissue and organ perfusion. Thereby, it improves the arterial blood pressure, decreases the inotrope requirement, increases left ventricular function and cardiac output. Cortisol replacement has to be done. Thereby, it improves the hemodynamics. It reduces the inflammation by attenuating the effects of pro-inflammatory cytokines released as a consequence of brain death. Thereby, it improves donor organ function and graft survival. It increases the tissue oxygenation and donor lung recovery. So, methylprednisolone 15 to 20 mg per kg is administered routinely. So, this is termed as something called as triple therapy. That is vasopressin, methylprednisolone, insulin, thyroxine. These 4 things are being given. Here, vasopressin is 1 unit bolus followed by an infusion of 0.5 to 4 units per hour. Methylprednisolone, as said earlier, 15 mg per kg. Immediately after the diagnosis of brain death and every 24 hours afterwards. Alternatively, 250 mg followed by 100 mg per hour until organ is subscribed. Insulin infusion is maintained in order to maintain a blood glucose level between 80 to 150 mg. And thyroxine T4 20 microgram bolus and is followed by 10 microgram per hour. And T3 is administered as 4 microgram bolus followed by an infusion of 3 microgram per hour. The replacement of these things will have a better hemodynamic stability in these patients. Other managements are enteric nutrition should be continued as it increases the glycogen supply and has the potential to optimize allograft function. Dyselectrolemia is to be corrected priorly. Hypothermia to be managed so that we have to maintain a temperature more than 35 degrees Celsius. Hematological support so that the INR is less than 1.5, platelet count is more than 50,000 and hemoglobin more than 7 grams. Our ultimate goal is to avoid coagulopathy and further complications. There is something called as rule of hundreds. Certain factors to be maintained more than hundreds in this patient for an organ brain death patient posted for organ donation. That is, the systolic blood pressure must be more than 100 mm of Hg, heart rate less than 100 beats per minute, urine output more than 100 ml per hour, and PaO2 more than 100 mm of Hg. The random blood sugar level should be around 100 mm of 100 mg per deciliter, and hemoglobin it is 10. So for remembrance sake, it is termed as 100, 10 gram per deciliter. This is the rule of hundreds. Now coming to the intro of management. Same principles as an ICU setting. Assure hemodynamic stability. Adequate amount of cross-match blood must be made available. Blood diuresis to be followed. Adequate muscle relaxation and a normothermia of temperature around 35.8 degrees Celsius to 37.8 degrees Celsius to be followed. Heparin must be administered before cross clamp of the aorta to prepare for the infusion of preservative solution into the organs to be pronounced. For lung procurement, the anesthesiologist will likely to be asked to administer positive pressure births to inflate the lung prior to removal of subsequent packaging for transplants. Organs are removed in the following order. That is heart, followed by lung, liver, pancreas, and kidney. Antimicrobials. If fever is there, we can use third generation. Fever is not there, we can use third generation cephalosporin. If fever is present, vancomycin 1 gram every 12 hours or peptas 4.5 gram every 8 hours. Or vancomycin 1 gram every 12 hours along with meropenem 1 gram every 8 hours. This is a summary of the organ donor management. For general management, central line insertion and monitoring, arterial line insertion and monitoring, nasogastric tube insertion, Foley's catheter insertion, care for the lines, intubation tube, Foley's catheter, consider changing whenever necessary. Maintain the head of the bed at 30 to 45 degree elevation, continue side to side body rotation and positioning, warming blankets to maintain the body temperature around 36.5 degrees Celsius, maintain the pneumatic compressive device for preventing deep vein thrombosis, eye protection, frequent airway suctioning, ulcer prophylaxis, broad spectrum antibiotics. Regarding monitoring, as we discussed earlier, the same. And therapeutic targets, you remember the rule of hundreds, right? The same. Along with it, certain additional things like potassium level to be monitored and hemoglobin around 10, as said earlier, and central venous and mixed venous oxygen saturation around 70%. And lactate levels must be less than 3 millimoles per liter. Hardly urine output must be around 100 to 300. So, and hypothermia to be avoided. A success in donor management depends upon, it's a team goal. It depends on prior planning and donor protocol, a continued ICU care following the goals already said, yearly use of steroids, methylprednisolone, and yearly use of vasopressin, that is the triple therapy, yearly use of flow monitoring, standardization of care, and audit. These results in more success in donor management. These are my references. Thank you. You can have a look at the summary. The main thing to be considered is this rule of 100. That is, the systolic blood pressure more than 100, heart rate less than 100 beats, urine output more than 100 ml, pulmonary artery oxygen more than 100, and random blood sugar nearly around 100, and HP of 10 grams. And for declaration of brain death, as you remember, a committee of 4 members, 2 tests has to be done, 4 hours apart. And the test involve, this is the brief. The test, it has 5 lists. Do you remember? Step 1 is prerequisite to exam, so that rule out the other causes and ensure this is brain death. Establish the cause for which the patient is in coma, any trauma or anything else. Absence of brain and brainstem functions to be involved. For that, initially the patient must be comatose, unaware, unresponsive, and the reflexes must be absent. So we have seen all the tests, whatever, and absence of spontaneous breathing efforts, and consider confirmatory testing, like confirm the force test and go for ancillary testing methods. The main thing to be remembered here is how we do the apnea test. And we can abort the procedure whenever the patient is hemodynamic unstable or the saturation falls. This is a brief. You can have a look at it. Thank you.